This video is going to cover acute respiratory failure, acute respiratory distress syndrome, and pulmonary embolus. So with acute respiratory failure, we have altered gas exchange on room air. This often can happen with patients who have chronic respiratory conditions that decompensate. For example, that COPD patient who is very tightly compensated and controlled, but then they get an upper respiratory infection and it kicks them into an acute decompensation and everything starts to tank. So we have hypoxemia, a PaCO2 less than 50, and or hypercapnia, a PaCO2 greater than 50. Now those two by themselves, you remember when we did our ABGs, oftentimes patients with chronic COPD, chronic respiratory conditions, will have low PaCO2, high PaCO2, but they are compensated. They have a good pH. This person in acute respiratory failure has a low or low end of normal, right at the bottom, 7.35 for their pH. Differing from chronic respiratory failure because patients can have terrible gases, as you see here, but their pH is fine. The problem is, again, that little tiny bit of problem can tip them out of their compensation and into a decompensated situation. Now, our pathophysiology, our causes of acute respiratory failure are alveolar hypoventilation, so the inability to get air in and out of your lungs. Those can be mechanical issues like obesity, or chest wall deformities, or neuromuscular conditions that inhibit the ability of the lungs to expand and contract and take in O2 and expel CO2. So you can start thinking about what types of patients would be prone to hypoventilation. Then you have diffusion abnormalities. They may be able to get air in and out of the lungs just fine, but once it gets to the alveoli, there's something that's causing them not to be able to exchange gases at the alveolar level. So that could be somebody with pneumonia, with a lot of consolidation, a lot of mucus accumulated. It could be somebody with acute respiratory distress syndrome that we're talking about in a little bit, that is, their lungs are full of fluid. Or congestive heart failure. Their lungs are full of fluid and they can't exchange gases because all of that alveolar surface area is blocked by all that fluid. So those are usually the reasons why somebody goes into acute respiratory failure. The inability to ventilate effectively, or the inability to exchange gases at the alveolar level, or usually a combination of the two. So our treatment of acute respiratory failure is to treat that underlying cause. Treat the pneumonia, put in a chest tube to help their lungs expand better, put them on mechanical ventilators. And some of our nursing assessments, think about what you're going to be looking at for that patient with acute respiratory failure. What types of labs are going to be monitored? Things like their ABGs. We're going to be looking at their pulse ox, their respiratory status, their focused respiratory assessment. And if they're on a ventilator, things that we're going to talk about in another video is how do we manage those patients who are on ventilators and what complications are we looking for. So that's acute respiratory failure. Problems with either poor ventilation or poor exchange of gases at the alveolar level, or a combination of the two. Then we get into acute respiratory distress syndrome, oftentimes presenting with very similar signs and symptoms, but the etiology is different. With ARDS, we have the systemic inflammatory response syndrome, or SIRS. So some sort of massive insult to our body, either a massive infection or a trauma. Because what our body does when it is faced with some sort of trauma will basically go, holy crap, what's going on here? I need to send all of my compensatory mechanisms and my inflammatory mediators to the site of the problem. But if it's systemic, the body is releasing massive amounts of chemical mediators. And these chemical mediators cause damage to capillary membranes. It is body-wide, body system-wide, but we're going to just focus on what's going on in the lungs right now. So it's damage to the alveolar capillary membrane. This causes increased capillary permeability. So now the fluid that's in the capillaries is leaking into the alveoli, and we have pulmonary edema. We have non-cardiogenic pulmonary edema. You learned back in Nursing 110 about congestive heart failure and the fact that when we have left-sided heart failure, blood backs up into the lungs and fluid accumulates in the alveoli. That is cardiogenic pulmonary edema. This is a scenario with ARDS of someone whose heart is probably functioning quite well. It's not backing up from the left side of the heart into the lungs. It's the leakage of fluid from the capillaries into the alveoli causing pulmonary edema. This leads to microatelectasis because what's happening is the type 2 cells on the alveolar capillary membrane are unable to produce surfactant. And the function of surfactant is to keep the alveoli from sticking together at the end of exhalation. So it keeps the alveoli expanded and it keeps them from sticking together. So if we don't have enough surfactant, the alveoli are going to collapse. So now we have even less alveolar surface area that can exchange gases. So patients have very severely impaired gas exchange. Now in your book, there is a table on page 299 that talks about the common causes of ARDS. So look at those, learn those, see which of your patients have the potential to go into acute respiratory distress syndrome. It's not just patients with sepsis, although that is a very, very common cause. Pancreatitis, which is a leading cause of sepsis, can cause ARDS. So look at that box on page 299 about some of the causes of ARDS to determine what's the worst thing that can happen to my patient today. So some of the symptoms of ARDS. The respiratory symptoms. They're going to have dyspnea and tachypnea and are going to be hyperventilating in the early stages. So maybe they're going to be in respiratory alkalosis early on because they're breathing very rapidly. They're trying to compensate. They're trying to blow off CO2. And that hyperventilation with normal breath sounds is very common in the early stages of ARDS. We look at something called VQ ratio, which is a ventilation perfusion ratio that is measured using the VQ scan. And that tells us how well the patient's ventilating and then how well they are exchanging gases at the alveolar level. And it should be right about 1:1. If that patient's having problems ventilating or they've got a lot of fluid in their lungs and they can't diffuse gases, their VQ ratio is going to be abnormal. We're going to be looking at vital signs, increased temperature and pulse. Temperature possibly because of an infection, a systemic infection. Heart rate is going to be elevated. When you can't get enough oxygen, your heart beats faster in order to get more oxygen into your system. We'll do an EKG. Unless they have underlying cardiac problems, the EKG will probably be very normal because there's not a problem in the heart. It's a problem of this systemic inflammatory response syndrome causing the leakage of fluid into the lungs. So an EKG could potentially rule out a cardiogenic problem for why that patient's in fluid overload or appears to be in fluid overload. Hemodynamic readings, which we're going to talk about more in detail when we get to cardiovascular, they should be low to normal. Again, because our cardiac function is usually normal in these situations with ARDS. It's a systemic inflammatory response causing leakage of fluid into the lungs. The X-rays are going to start getting worse and worse and worse, and they're going to progress to something that you may hear called whiteout or ground glass appearance. When you look at that X-ray, you are going to see all that cloudy area in that x-ray is fluid in that patient's lungs. So that is that whiteout. You can only see in this upper area up here, there's any kind of clear lung fields. Everything else is full of fluid. So our treatment of ARDS, we are going to put that patient on a mechanical ventilator. They're going to be intubated and they're going to be put on a mechanical ventilator. And we are going to put something on there called PEEP, positive end expiratory pressure. We're going to talk a lot more about that when we talk about ventilators in another video. But what PEEP does is it gives them a little extra puff of air at the end of exhalation, so positive end expiratory pressure. And it inflates those alveoli so they don't collapse and stick together at the end of exhalation because of that reduction or lack of surfactant. Some of the other things that we're going to be doing is treating whatever the underlying problem is, the infection or other trauma that has caused this SIRS response. So corticosteroids to reduce inflammation, antibiotics to reduce infection. We have to be very careful with fluid resuscitation, fluid replacement with these patients, because we could put them into fluid overload and cause more fluid to go into their lungs if we keep pumping a lot of fluid. So we have to be very, very cautious in our application and our administration of fluid. Because they're on a ventilator, they're going to probably have an a nasogastric tube, enteral feeding tube of some sort, because we cannot ignore their nutrition. That's going to be key in helping them to heal from whatever the underlying problem is. So nursing failure to rescue, third leading cause of U.S. deaths. We have to be vigilant with our patients. When I talked in prioritization and delegation about trends versus isolated changes in vital signs, physical assessment, that sort of thing, we have to be very, very cautious and really be alert to those trends, because oftentimes patients will not go critically down the tubes quickly, but they will have what's called a slow fade. So we have to be looking at things like problems with, complaints of chest pain, increasing shortness of breath, the hypotension, tachycardia, altered mental status. We have to be very, very vigilant and catch that patient and activate rapid response in order to make sure that nothing happens, nothing goes wrong with that patient. The last thing we're going to talk about on this, and oh, hello, there is a lovely pulmonary embolus. And so one of the things that we have to try to remember as to what can cause, what puts our patients at risk for pulmonary embolus. So something that you may have learned about at one time, and try to remember this, and it's called Virchow's triad. Virchow's triad are the three risk factors, categories of risk factors that predispose patients for DVTs. And any person who gets a DVT is always going to be at risk for that DVT breaking off, traveling throughout the body, and because we're discussing acute respiratory issues, traveling to the lungs and blocking the pulmonary circulation with an embolus, a pulmonary embolus, and causing a serious respiratory complication. So there are three components to Virchow's triad. So always be thinking about your patients as to, do they fit into any of these three categories of Virchow's triad? And if they have more than one risk category, then obviously their risk of DVT is going to be even higher. So we're going to look at Virchow's triad. We're going to look at venous stasis as the first leg of our three-legged stool of Virchow's triad. Venous stasis, so anytime blood pools in the lower extremities, you're going to get blood clots. So think about all of your patients who might possibly have venous stasis and be at risk for a DVT. The second leg of the three-legged stool is altered coagulability. So certain disease processes cause that patient to clot their blood a lot more quickly than what they should. So think about what kinds of conditions that your patient could have that could cause altered coagulation. Things like malignancies, oral contraceptives, any kind of hormone replacement can cause abnormal clotting. Systemic infection, the SIRS response, we're going to talk about that in detail when we get into the area of shock and septic shock. And then the third leg of the triad is damage to vessel walls, so trauma to the blood vessel walls. So it could be surgical traumas, it could be motor vehicle accidents or other types of those types of traumas to blood vessels. The fact that you've had a previous DVT has caused damage to your blood vessel, and that will cause you to develop and be at a higher risk of developing a DVT in the future. So think about your patients now, what their diagnosis is, what their risk factors are for either venous stasis, altered coagulation, or damage to their vessel walls, because these patients, you've got to worry about DVTs, and if they get a DVT, you've got to worry about a pulmonary embolus. In class, what we're going to do is a case study, and we're going to be talking about a patient with a DVT that developed into a pulmonary embolus. So be thinking about risk factors, how you're going to prevent the DVTs, signs and symptoms of pulmonary embolus, various diagnostics to determine whether or not they have a pulmonary embolus, what's the pharmacology, specifically thrombolytics and anticoagulants, what are some of the surgical treatments, and then what is the discharge plan and the discharge teaching. All of that is going to be discussed when we do our case studies. So if you try to answer some of those questions before you get to class, you'll be ahead of the game.